Good day. My name is Elena Silvia Shelby. I'm a medical geneticist at Dr. Nicolae Romanescu National Clinical Center for Children's Neurorecovery in Bucharest, Romania. And today I'm going to talk about Mic-Pch syndrome as a rare cause of mental and motor disability. The Mic-Pch syndrome, which is the abbreviation of mental retardation with microcephaly and pontocerebellar hypoplasia, is a dominant X-linked genetic disease caused by the heterozygous loss of the function of the Cas gene, which is a gene playing a very important role in the development of the brain. And the frequency is very rare. The disease is very rare. According to Orphanet, the prevalence is below 1 in a million, and some sources say that there have been reported over 50 girls globally, and other sources say that actually below 100 girls have been reported in the literature, and just a few boys with this syndrome. As the name says, this syndrome is characterized by congenital microcephaly, pontine and cerebellar hypoplasia, as well as other features which are just as nonspecific as the previous ones, like postnatal growth retardation, severe intellectual disability, autistic manifestations like self-mutilation or stereotypical movements, severe motor retardation, axial hypotonia, hypertonia of the limbs and spasticity of the limbs, as well as dystonic movements. Also, in some cases, ocular manifestations can occur, such as strabismus, optic nerve hypoplasia, nystagmus, cataracts or retinopathy, as well as in about, let's say, a quarter of the cases, neurosensorial deafness. The patients have somewhat non-specific facial dysmorphism, although let's say it can give us a hint about this syndrome, namely a prominent forehead with hypertelorism, epicanthus, arched eyebrows, very prominent eye globes, macrotia with prominent ears, a long philtrum, a short nose with a very flat bridge and a bulbous nose, microretrognathia, and prominent maxillary. Usually the patients never acquire language, and only quarter of these patients can acquire walk. And these are some images from various articles of patients with mutation in the Cas gene. As you can see, the patients have quite prominent eyes and ears. They have a flat nasal bridge, they have a bulbous nose, they have a prominent mandible, and also prominent maxillary, and also microretrognathia. But some of them look just normal, so they wouldn't even attract our attention if we saw them on the street. And now I'm gonna present a case from our hospital of a 3-year-old patient with a absolutely non-significant family history. Parents were not consanguineous, there were no genetic diseases known in the family, and she had a 9-year-and-a-half brother, which was healthy. The birth was term by C-section because the mom opted for C-section, and the Apgar score was 9. And the first thing, which was, let's say, not normal, which was remarked, was that the patient had microcephaly. And then, starting with the age of 1, the patient started developing seizures, which were consisting in myoclonies, which were consequently confirmed by EEG. According to the mom, the patient could hold her head at the age of when she was 2 months old, and she could sit without support at 7 months. But following the onset of the epileptic seizures, she lost these milestones. And When we consulted her, she was receiving treatment for the epileptic seizures, and they were behaving quite well under this treatment. Also, the mom told us that the patient had swallowing problems. She had presented frequent pulmonary infections, and she had a few episodes of aspiration pneumonia. When we consulted her, she could not support her own head, she couldn't sit, she had very severe axial hypotonia, she had severe spasticity in the limbs, she had dystonic movements, and she could only pronounce one word, mama. She had microcephaly, and she was lacking sphincter control. The MRI showed the pontocerebellar hypoplasia associated with the Dandy-Walker variant and the right parietal venous angioma. I have to remind you that the Dandy-Walker variant consists of cerebral vermis hypoplasia, of a very enlarged posterior fossa and an enlarged foreventricle. The SNP array analysis, which consists in the hybridization of DNA from the patient, which is fluorescently marked with fragments, of course it's fragmented, with fragments of DNA of a reference genome, which is marked in another color. For example, the reference genome is red, the patient's genome is green. And then according to the color that you get, you can detect the duplications or the deletions. This SNP array was normal. The liver enzymes were normal, creatine kinase was normal, LDH had normal values. And this is our patient, which I have shown you. And of course, we knew that there was a genetic disease involved, so we sent for an NGS panel for microcephaly and pontocerebellar hypoplasia. We found a variant of unknown significance in the Cas gene located in an intron. But although the variant wasn't reported in the populational databases and actually it wasn't reported anywhere in the literature, and the in silico analysis were predicted that the substitution was annulling a splicing situs in the third intron, leading to an abnormal splicing. We presumed that the variant might be pathogenic. So the next step for maybe a reclassification of the variant and to establish the segregation mode was the analysis of the parent. Of course, the parents were given genetic counseling, and parental testing was recommended, but as they didn't want to have other children, at least for now, they decided not to continue with the testing. And I have to say that the variants of unknown significance, unfortunately, or maybe fortunately, cannot be tested in pregnant women. It's illegal to do that. So this information wasn't really giving us clear result for future pregnancies. But the fact that the variant was absent from populational databases and was predicted by in silico tests to be pathogenic, and also was overlapping the patient's phenotype, we presume that it was actually pathogenic. So in conclusion, this syndrome is present in the girls, mainly in girls with a severe intellectual and motor disability, with microcephaly, usually accompanied by epileptic seizures, with specific facial dysmorphism like oval face, prominent eye globes, prominent ears, hypertelorism, short nose with a flat bridge, bulbous nose, as well as ophthalmologic manifestations, optic nerve hypoplasia, coloboma, nystagmus, and auditory manifestation like neurosensorial deafness in about a quarter of the cases. And only a quarter of the patients can acquire walk, and the language is nearly absent in most of the cases. The syndrome is caused by monoallelic mutations in the Cas gene, which encodes the serine protein kinase dependent of calcium calmodulin, which is a protein with a lot of domains interacting with more than 20 other proteins. The management consists in a neurologic evaluation and monitorization, including a brain MRI, EEG, evaluation of the motor and cognitive acquisition, such as, for example, language, psychiatric exam, evaluation of the nutrition, ophthalmologic and auditory exam, heart ultrasound, as well as the abdominal ultrasound with a focus on the genitourinary system, monitoring for various abnormalities, as well as genetic consult. And unfortunately, currently the treatment is only symptomatic. Management of the seizures, kinetotherapy, logotherapy, nutritional support, management of the psychiatric manifestation, treatment of the deafness, as well as the visual impairment. The disease has a X-linked inheritance, dominant X-linked inheritance pattern, most of the casing appearing de novo. Nevertheless, germinal mosaicism can appear, so we can have apparently healthy parents. We cannot find a mutation in the blood test, in the sequencing, gene exome sequencing or gene panel for microcephaly and pontine and cerebral hypoplasia. But the parents can have a germinal mutation, so part of their germinal cells can have the mutation, and that's why it's advised to do either prenatal testing at every pregnancy, or start with IVF, but with a mention that the rate of mutations following IVF is 10 times higher than the rate of mutation following normal conception, mainly due to imprinting abnormalities. And so far, no person of the feminine sex has reproduced. The differential diagnoses are numerous, like X-linked mental retardation, which can be syndromic or non-syndromic, pontocerebellar hyperplasia, which can have many types, X-Fragile syndrome, as well as other syndromes, Wilson-Turner, R-Scott, and others. So, in conclusion, this syndrome is very rare. For sure, under 100 cases of girls which were affected have been reported so far, and our patient had a mutation in the Cas gene which had never been reported but was overlapping the Mic-Pch phenotype. The variant was predicted as deleterious by in silico tests, but it is absent in the populational databases, so that's why we believe it's pathogenic. And we are hopeful that this presentation can extend the knowledge on this very rare syndrome, and thus help make do a faster diagnosis of this syndrome. I would like to thank you very much for your time and your attention. Goodbye.